invitation to present tonight. Okay, can everyone see? Is that okay, Helen, Shirley?
Yes, it is.
All right, so tonight's talk is all about burn management, and I'm going to try and keep it as relevant as I can for general practice. Throughout the presentation, hopefully you'll get an idea from me about what it's like to assess burn depth. We'll be talking about when to refer patients to a burn service, and we'll also be describing appropriate initial management, including all those things: first aid, blister management, choice of dressings, etc. And there's a few slides towards the end about some of the considerations when we are managing burns in special areas of the body, so the hands, face, perineum, feet, etc. So we've got 90 minutes, we should fill up the time adequately. I've got halfway through approximately, there'll be a little poll, and I'm going to test you with some pictures of burns, and I'm going to ask you to tell me what depth of burn it is. But I've got, in general, there's lots of pictures, there's videos, so we're going to go through the whole thing. And as Shirley said, or Helen said, we're going to save questions for the end, and I'll do my best to answer as many as I can. Okay, so this is what it's all about when we want to assess how deep a burn is. I have come up with this sort of simple way in which we can identify burn depth or judge burn depth, and I teach this to all the registrars that come through our unit. And it's basically two things. The first thing is you need to take a history. You need to get the mechanism of what happened. And I'll go through sort of common mechanisms that we see all the time, and relate that to the likely depth of the burn. Second of all, we need to look at the color of the burn. And I've got, again, lots of photos that we can go through, and I can help clarify how we determine burn depth based on the color of the burn. And I've simplified this into mechanism and color because these are the two things that I've come to rely on. And these are the only two things that I reliably get when I receive a referral from a GP or a colleague in another hospital or someone in the community. I reliably get these two things. I get a brief little history of what happened, and I get a nice high resolution color photo of the burn. So this is all I need to go on. And I realize this is practice, this comes with practice. But hopefully after tonight's presentation, you'll walk away with a sense of understanding about why these two things are the most important things. So the other thing to consider when we're dealing with thermal burns, and this is what you'll get from taking a history. The depth of the burn is simply a function of temperature versus time. The hotter something is, the deeper the burn. The longer it's in contact with the skin, the deeper the burn. And there's a relationship between those two things. So first things first, history. So these are some things that are very, very common that we see all the time when we get referrals from outside of the hospital, etc. And when I hear these things, when I hear the history, when I hear this sort of story, I am reassured, because most of the time these burns aren't that bad, and they're probably going to heal with conservative treatment. So the first thing is sun exposure. I have never seen a burn from sunburn that requires a skin graft. Almost all sunburns are epidermal in nature. The really bad ones are superficial partial thickness. And we all know that most sunburns heal within a week, maybe 2 weeks if there's some blistering. But you know, sunburn is an insignificant mechanism. Similarly, if there is hot water, so household temperature water, and it's a scald in an adult, 9 times out of 10, that's nothing to worry about. That burn is probably, again, superficial partial thickness, and it'll heal up fine. They won't need surgery, and everything's going to be fine. If, however, it's a child and the hot water is a boiling kettle or something that's, you know, cooking on the stovetop, then it's a different story. Those sort of scald injuries in the kitchen and the bathroom for children are often deep, many of which will require a referral to a burns unit, and some of them will require skin grafting. If there's very brief contact with something hot, so again, that comes back to the temperature and time thing. So a classic example of this is brushing a leg or a body part or a limb up against a hot engine part. It might be a motorcycle exhaust or an engine block or something like that. And if you just brush up against it and it's just very brief, it's unlikely to be deep. You know, it's probably only going to be very superficial. The next one there, gas ignition or flash burn. So when the classic one here is lighting a barbecue, a gas barbecue, you know, the gas accumulates when you turn on the gas switch, and it doesn't ignite straight away. So you keep on trying to ignite it with a match or a lighter or something like that. The gas accumulates, and then there's a flash burn. Most of those LPG gas flash ignition burns are superficial. And we don't really have to worry about them. They might be quite significant. Sometimes these ones, if you're standing in front of the barbecue, can be quite a significant surface area. So you can burn, you know, if your whole front of your body, your face, your neck, there could be a little bit of inhalational component to the injury, but the burns themselves are very unlikely to be deep. Similarly, we see radiator burns, steam burns in adults, again, not usually deep. In contrast to that, whenever I hear these stories, I'm almost penciling these patients in for an operation. So as soon as my registrar says, oh yeah, the patient's clothes caught on fire, it's like, well, you know, we'll book a bed, we'll get them down. You know, I don't really have to see necessarily a photo to know that these burns are going to be deep. And it's, again, it's a function of temperature and time. Most people, you know, when their clothes catch on fire, they do struggle to get them off quickly, and that causes a deep burn. Similar situation with hot water, and this is commonly encountered in elderly people who spill hot liquid in their laps while they're sitting in front of the TV or at the dinner table. And in elderly people with cognitive impairment, with mobility issues, their reaction times are reduced, and they often have prolonged contact with that hot liquid. And the location of the burn in those patients is also a consideration to make, because elderly people have thin skin, and they typically scald themselves on the inner thighs, and that part of the body has thin skin to begin with. Any burn involving an accelerant, so petrol, kerosene, metho, particularly if the patient gets liquid accelerant on their skin and their skin is on fire, then that's going to be deep. So we see a lot of flame burns from accelerant. And a common thing is patients who throw petrol or diesel onto a burning fire to get it going, or to, you know, restart it or whatever. And we know petrol in particular is very, very volatile. And when it burns at, you know, very, very high temperature. So those burns are probably going to be deep. Patients with diabetes, we get, you know, two different patterns of injury with patients who have peripheral neuropathy from diabetes. In summertime, they walk on a hot surface and they don't feel their feet burning. So it's usually sand at the beach or a hot pavement or bitumen. And in winter, those same patients sit in front of a heater or a fire and they burn their feet and they don't feel them burn. When I hear that, that's going to be deep because of the prolonged nature of the contact. And then when I hear hot oil on fire, so oil obviously has, you know, a range of temperatures. You know, when you're cooking, you can heat it up slowly. It will reach the smoking point at a certain temperature. And then if you continue to heat it, it will reach the flash point or the flame point. So when oil is on fire, when it's reached its flame point, it's usually scalding hot. And most of those patients will need a skin graft if they get oil that's on fire spilled on them. If I mentioned before about the exhaust pipe or engine part on a motorcycle, if the patient is pinned under the motorcycle and they're trapped there for, you know, several seconds, or some people it's a minute or two because the motorcycle's heavy, then that's going to be deep. Most chemical burns are deep, and there's two probably, you know, really common chemical burns we see, and they're both alkaline. One is from oven cleaner that might get onto your clothes or down into your gloves, and the other is concrete and lime burns from labourers, concreters, that sort of thing, where there is prolonged exposure to lime dust or concrete dust, and the patients will often just with that sort of burn, with lime burns, concrete burns, we'll often just notice it at the end of the day. So they potentially have had hours or several hours worth of contact with the lime. This is surprisingly common. This next one, electrical arc burns, that's a DC electrical injury from a car battery that arcs onto the wedding ring or a ring on one of the fingers. So if that happens, usually that's very, very deep dermal or maybe even full thickness. So they get a circumferential, you know, full thickness burn on their ring finger. And then self-harm burns, we're seeing more and more of this, certainly in my practice. I'm not sure what happens in general practice, but in hospitals, we are seeing more and more people self-harm. That's not only anecdotal, but that's also been, you know, published as well. A lot of the burn units in Australia are seeing lots of these, and because the, you know, injury is intentional, patients usually do a good job. So the burns are going to be deep. So next, I'd like to just remind ourselves about the layers of the skin, and I'm sorry if I'm being a little bit too simplistic, but I think this is an important concept just to remind ourselves on. Remember, there's two layers, the epidermis and the dermis of the skin, and the epidermis and dermis varies in thickness depending on which part of the body we're talking about. So on the palm of the hand, for example, we have very, very thick epidermis. That's the glabrous skin, that specialized skin with all of the skin adnexal structures like sweat glands. In the eyelids, for example, I guess the epidermis will be very, very thin, but also the dermis will be very, very thin. So a burn in an area of the body that has thin dermis and thin epidermis is probably going to be deeper than that same burn occurring in a part of the body with thick skin. When we have blisters, and again, this is an important concept just to remind ourselves of the blister fluid accumulates in the space between the epidermis and the dermis. The depth of the burn is broken up into these things. This is the sort of modern nomenclature. You've probably heard of first, second, third degree. So that's superficial, mid-dermal, and deep dermal burns. That's the old system. So superficial dermal burn was a, you know, a second degree burn. A first degree burn is an epidermal burn, and a third degree burn is a full thickness burn. We now refer to burns in this way. So there's epidermal burns where there's no blisters. As soon as you see a blister, then by definition, the burn is at least partial thickness. So superficial, mid-dermal, or deep dermal. But it could also be full thickness, as we'll see. So I've got some pictures coming up. And then this is a take-home slide. These, we've talked already about mechanism and how important it is to get a history and just understand that temperature and time relationship when we're dealing with thermal burns. But then we got to look at the color of the burn. And this is where I, as the burn unit or the burn consultant will receive a photo on my phone or my computer, and I can look at the color of the dermis. And there's only 3 colors that I go off. And this was taught to me by one of my mentors who, you know, when I did my burn fellowship, and he said, there's only 3 colors. It's pink, red, and white. Pink is superficial, white is deep, and red is somewhere in between. So we'll go through that at the moment in a second. So here's a burn. This was from hot oil. So it's a scald burn. It wasn't on fire, but it was heating up in the pan, and somehow it got spilt onto the back of the hand. I like putting this picture up because it's one of the most impressive blisters that you'll ever see. But second of all, it just highlights the fact that I can't tell the depth of the burn based on the color because the blister is in the way. When I say the color of the burn, you need to look at the color of the burn. What I mean is you need to look at the dermis. So if I go back to the blister diagram, if the blister is obscuring the view of the dermis, then we have to peek in somehow. We have to look underneath the blister. Now, I'm not saying we have to de-roof all the blisters, or that's I guess a talk which we can address. That's an issue we can address later on in the talk. But in order to judge the depth of the burn based on color, I need to see the underlying dermis. So here's the same patient. We've de-roofed or partially de-roofed the blister. And now there's some congealed sort of clotted serum or blister fluid lying on the surface of the dermis. But this underlying structure here, the pink stuff, that's the dermis. So the epidermis is the blister. It's sort of crumpled up in the corners there, and plus we've taken off a large section. And what we're looking at underneath the epidermis layer is the dermis. And this is what I mean by looking at the color of the burn. We need to see the color of the dermis, not the epidermis. And I think you'll all agree that this burn looks pink. Okay, so this is a superficial partial thickness burn. It's a partial thickness burn because there's a blister, and because it's pink, it's in the very, very superficial layer of the dermis. So I'll just go back to this diagram here. Superficial dermal burns are up in the top part of the dermis and appear pink. Really, really pale burns are in the deep part of the dermis and they appear pale white. And then if you ever see a burn that's really beefy red, that's probably mid-dermal in nature. Okay. So I've got some pictures as an example. So epidermal burns, the old first degree burns, a typical example of that is sunburn, and it's just erythema. So there's no blisters. And we know from experience that these burns are likely to heal within a few days. And all you need to do is apply emollients or moisturizers to the area and stay out of the sun, and they will heal up just fine. And the mechanism of this one, boiling kettle over the back of the head and neck. If I hear that story, I know it's probably going to be okay. 1, because it's an adult and most scalds in adults aren't that bad. And 2, because it's the back of the neck, there's really thick skin there. So even though it's hot boiling water, because of the thick skin, it's probably going to be fine. If this was a burn in the lap of an elderly person, it might be a different story. But because it's on a thick skin area, it's probably fine. So epidermal burns have no blisters. So first degree burns, no blisters. As soon as you start seeing a blister, if the burn blisters, then we're dealing with a partial thickness burn. So really, really superficial burns, superficial partial thickness burns might look like this. So this is a young girl, slipped at work and the hand went into a deep fryer. Now most deep fryers are probably 160, 180 degrees. And you might think, well, hearing that, well, gee, that's going to be deep. But most of the time, this happens at Macca's or, you know, KFC or wherever. Most of the time, they look like this. They're just bright pink. And some of you might be able to see the blister that's starting to form here. There's a bit of blister fluid accumulating just over on the forearm here, on the upper part of extent of that burn. This is a superficial partial thickness burn because the contact time, although it's hot oil, the contact time is usually very, very brief. And then usually the patient has good first aid. They usually, you know, 20 minutes, cool running water. And because of those things, the burn is usually superficial partial thickness. This is a day 5 photo just to prove to everyone that, you know, it's healing fine. Young people tend to heal quicker than adults as a general rule. And because it's a superficial partial thickness burn, it's going to heal probably within a week, 7 to 10 days, roughly. Here's another superficial partial thickness burn. This one was from petrol. And I know I said most accelerants, you know, when you hear that word accelerant burn, you know, throwing petrol on fire, it's usually deep. Well, this patient was just lucky. You know, this is like the exception to the rule. Maybe they were standing a little bit too far away from the action when it happens, you know, fortunately. Again, this is a partial thickness burn because of the blister. So the blister, the epidermis is sort of crumpled up along the edge here. And what we're looking at here is the underlying dermis, which I hope you'll agree is pink. There might be some paler areas in parts, but on the most part, we have a pink superficial partial thickness wound. There's also another clue in this photo that suggests to me that it's a superficial partial thickness burn, and that is the moisture. You can see the light reflecting off the surface of the dermis, and it appears moist, so it's probably superficial partial thickness. If it was very, very dry and pale pink, and I've got some photos coming up of that particular, you know, case or that scenario in a second. If it was pale and dry, that's a different story. That's probably deeper. Next is mid-dermal burn. So remember I said if you ever see a burn that's really red, it's probably a mid-dermal burn. So this is the classic example of what a mid-dermal burn looks like. So this young female, her synthetic dress caught alight. So, you know, clothes catching on fire, you know, based on the mechanism, the burn's probably going to be deeper. And this photo demonstrates quite nicely another point about burns is that they're often not the same depth throughout. We often have different depths. So on the top edge here, you can see some pink, moist, superficial partial thickness burn. And then I would suggest that the red sort of beefy area is very, very characteristic of a mid-dermal burn. And then you've got that greeny sort of gray eschar in the center, little patches of that. That's probably, you know, deep dermal or maybe even full thickness patches in the middle. And maybe that's where the synthetic dress has sort of melted onto her skin the most. But that beefy red color is very, very typical of mid-dermal burn. And then this is day 7. So this is a week later. And you can kind of see that it all kind of makes sense now in terms of the different depths of burn. So up here, I'll just draw your attention to the bit that was superficial partial thickness at the start. It's actually healed by day 7. You can see that dry, shiny appearance. That's actually new epithelium. So that part of the wound has re-epithelialized. The mid-dermal section, so the vast majority of it, is still sort of pinky red, but I would say that that's close to being healed. Maybe it's another week off being healed. But then there's these patches of deep dermal or maybe full thickness burn in the center. They're going to be another few weeks off healing, probably. But we never saw this patient again because she was lost to follow-up. She never came back, so I don't have a follow-up photo for her. Here's another a good example of a mid-dermal burn, and this is a really good example of this blotchy sort of red color that you see in the dermis. Again, we've got islands of that greeny sort of eschar, which is probably deep dermal full thickness areas, but most of this burn on the foot here is actually mid-dermal. And what we think is going on here, that all of that red staining is probably damage to capillaries in the mid-dermis, and we get extravasation of red blood cells and we get staining of the dermis, giving it that red appearance. And then we come to deep dermal burns. So these are the pale sort of white burns. This is an example of a young male, and this is the usual demographic who you know, throws something on a fire, petrol usually. And you can see that this dermis, well, first of all, it's a partial thickness burn, probably because of blistering. The blisters come off completely, and what we're looking at here is a very dry, pale appearance of the dermis. And this is that classical deep dermal appearance. And there's lots of cooking analogies in burns. And a good one I like to use is cooking an egg white or a chicken breast, or, you know, something like that, where, you know, an egg white starts off as translucent. The albumin is, you know, see-through. But when you heat it up and you cook it, the albumin in the egg white is denatured through heat, and it turns opaque. And the same thing happens in the dermis. Remember, the dermis is mostly collagen and elastin. And then there's some adnexal structures like hair follicles and sweat glands and oil glands and nerve endings and stuff like that. But most of the skin is protein, is collagen. So when you denature collagen, it goes from a translucent color, nice pink color where you can see the capillary refill, to an opaque, pale white sort of appearance. So you're literally just cooking, you know, the proteins in the skin and denaturing them, turning them opaque. This is a contact burn. This is that, you know, classical injury where the patient's trapped between a hot injured part and something else. So prolonged contact with a hot injured part, we know from the history that that's probably going to be deep. And then there's a nice example of all of the different depths of burn in this picture. So right in the middle there, where the heat is most intense, the collagen has been denatured, it's dry, it's pale white. So we know that that's deep dermal, and based on the mechanism, it could even be full thickness. If you tested for capillary refill in the center there, obviously there's none, because, you know, all the blood vessels are being coagulated, and so there's no blood flow in that dermis. It also might be insensate because of damage to the nerve endings. So that's the deep area in the middle. Surrounding that, there's an area of deep dermal to mid-dermal burn, that red sort of appearance. And then surrounding that even further still, as the heat sort of dissipates from the center, there's probably an area of superficial partial thickness burn. And then this is what an oil scald looks like when the oil is on fire. So, you know, you might think that, you know, that young girl who dipped her hand in the deep fryer, you might think the hand's going to come out looking like this, but it doesn't, because it's very brief and the oil's not at flaming point. When the oil gets to flaming point and it spills on your hand, it is probably 350, 400 degrees plus. So this produces a very deep burn. So you can see on the back of the thumb there, that's the good area to look at down there. You see the back of the thumb, that's pale white. That'll be insensate, no capillary refill. It's dry, and it's got that pale white appearance, which is a deep dermal burn. And there could even be areas, when we operate on this, there could even be areas of full thickness burn within that burn. Burns are often, one of the things to know is burns are often not the same depth throughout. And then just a brief reminder of what happens when you're dealing with darker skin types. Remember, the melanocytes are in the basal layer of the epidermis. So when you get a blister, patients will lose the melanocytes, the pigment in their skin over that burn. So this is a patient with darker skin, and you can see the blister there with all the melanocytes in it, crumpled up in the corner. And what we're looking at here is just, everyone, no matter what your skin type is, everyone has pink, dermis underneath. So this is a scald from hot food, hot curry, and it's pink, and it's moist. You can see the reflection there of the light on the wound. So this is a superficial partial thickness burn. And this is a big problem for some of our patients with darker skin, because the melanocytes, although they can repopulate the surface of the wound through, expansion from the hair follicles, because there's often little rests of melanocytes within the hair follicles. So melanocytes and keratinocytes can grow out from the hair follicles and repopulate the surface of the wound. But the melanocyte comeback isn't guaranteed. So patients will often end up with paler patches, almost like vitiligo appearance, where the melanocytes haven't quite repopulated the entire surface. Also, patients can go the other way. When darker skin types, when patients with darker skin types burn themselves and the melanocytes come back, particularly if the patient is exposed to sunlight too early, the melanocytes can really come back, and this whole area can actually become hyperpigmented in relation to their normal skin. So, although, not technically a scar, the hypo or hyperpigmentation problems that some of these patients have, can be quite significant for that patient. This is a young girl potentially with a pale spot on the back of her hand, so that could be quite significant for her. And last of all, when we're judging depth of burns, are the full thickness burns. Now, these are usually pretty easy to tell based on the history and based on the appearance of the photo. So this guy, this is obviously a full thickness burn. Like it's got that charred appearance, contracted appearance, and if you feel that, it's going to be like leather. And the other cooking analogy here is like, cooking pork belly, or getting that crispy skin on a pork belly. That's what happens. The skin is basically rendered, and the fat is sort of rendered underneath this burn, and it's like tapping on a desk. This is a young guy who works in a mine, and hot molten metal slag to the right calf, and usually it's brief contact, but because it's so hot, it's usually a full thickness burn. And then this poor young lady, we treated her a couple of years ago. She's 19. She got trapped under a motorcycle. It was really heavy. She was there for about 10 minutes. So the hot exhaust pipe has basically just cooked the back of her calf. Based on the mechanism alone, I didn't really need to see a photo of this. I knew it was probably going to be full thickness. So that's full thickness in the center. It's really, really pale. It's got that sort of contracted, dry appearance in the center. And then there's sort of a rim of erythema and sort of pink color around it. So full thickness burn. And then this is what we see a lot of diabetic peripheral neuropathy patients come through our clinics and our email referrals all the time. So this injury would have happened probably in winter, getting too close to the campfire. Some people, their shoes are on and, the shoe heats up and they just get a burn on their toes and on their feet. And because of the mechanism, because it's prolonged exposure to the heat, the burn is usually deep. So these are full thickness burns. Sadly for this patient, it usually means amputations of some of the affected toes if there's, full thickness gangrene. And that's just the top surface of that same patient. Full thickness burn in the middle there. And then this is a chemical burn. This is some guy who was riding his bicycle, and he happened to have a container of oven cleaner in there, which somehow leaked and sort of soaked into his shirt. And he did feel it sort of burning, but he had to ride all the way home. So prolonged contact, chemical burns are usually deep. I don't know if you can see, just with the eye of faith there, I can see thrombosed vessels under the skin, like little thrombosed capillaries. Some of them are hairs, but some of those red ones are probably thrombosed vessels. And that's what happens with chemical burns, full thickness burns. You get sort of coagulation of the underlying vasculature. Okay, so we've covered, we're probably halfway through the presentation, and I'd like to do some polling questions now. And it's just, I've got 4 examples of burns, and I just want to get from you, we'll put up some poll questions after each picture. And I want you to just have a guess or give me an idea of how deep you think this burn is. So this is a scald from hot oil from a deep fryer at work. Good first aid. That's great. Thank you very much. Still got some questions coming through, some answers coming through. Just wait another few seconds. So remember that the oil's not on fire, it's just a deep fryer. That's good. So yeah, most of you have answered probably what I would say is the correct answer, and that's superficial partial thickness. The reason I say that is because on the picture on the right there, where the blister has come away, you can see the dermis, and it does appear to me to be pink. Where the blister is intact, we can't actually see the underlying dermis, so it is a bit tricky. Where the blister is intact, it could be epidermal. And in fact, see on the back, see in that first web space, but between the thumb and the index finger where the epidermis is intact, that could be an epidermal burn, a first-degree burn. But the majority of that is probably going to blister, and I would say it's a superficial partial thickness burn. All right, so this is the next one. 31-year-old male, chemical burn from undiluted chlorine. So day 3 post-burn. So poll question number 2. That's great. Yep, I would say most of you got the right answer. I would say it's full thickness. The reason I say it's full thickness is because it's got that depressed sort of sunken appearance to it. And it's got a sort of black-gray sort of center, which is what we call eschar, which is, completely denatured burnt skin. And we've even got some like almost cavitation there. And I think there's probably subcutaneous fat that is starting to be exposed in the depths of that wound. So I would say it's full thickness, and it based on the mechanism. Most chemical burns are usually nasty. So yeah, full thickness is probably the one I'd go for. All right. Second last one, we've got 2 more to go. So this guy, 23-year-old male, fell into a campfire 3 days ago and hasn't received any medical attention since. So this is poll number 3, please. You can see some contamination in the wound there, like we've got bits of probably ash and dust and stuff that's in the wound. So this is a contaminated wound. Some of the blisters still intact around the edges. There's probably a mixture of depths of burns here. The pale white areas there. And then where the blisters sort of still intact might be a little bit more superficial, towards the peripheries of that injury. This one's a tricky one. Like, I could go either way on this one. I think it's either full thickness or deep partial thickness. The reason I don't think it's mid-dermal is because it's not really that brick red color. If you remember from some of those mid-dermal burns I showed you before, it's more a pale white color, especially that one just above the elbow, that one up there. It's really pale white. Based on the mechanism, I have to say, if I didn't see a photo of this, I would say it's full thickness, because most campfires are pretty hot. And what are people usually doing when they fall into campfires? They're usually drinking alcohol. So reaction times are a bit less, and people are a bit clumsy. So most of the time, if I hear that story, I think full thickness, but I can see why, it could be deep partial thickness as well because of that pale color. So that's a bit of a tricky one, and you could go either way. And it also highlights that it's actually quite difficult to judge the depth of the burn sometimes. And sometimes we don't know the true depth of the burn unless we take it to the operating theatre and we debride it, and then we get a very accurate sense of how deep it is. So yeah. And then the last one, mechanism, is a 17-year-old male, shirt caught fire whilst welding. And this is poll number 4. Oh, this is a good one. There's a nice mix here. This is going to be a good discussion, because I think this burn highlights a few things that and a few little traps, I think, when you're assessing a burn. So some of you have said epidermal burn, and I would agree with that. So some of the burn around the edges where there's no blister, that might be epidermal. But if you just go on the mechanism alone, your shirt caught fire, who's probably welding at work. So this is a young kid, shirt caught on fire. Most of the time, patients struggle to get their shirts off in time or their clothes off in time, and most of the time it's going to be deep. I would say deep partial thickness or full thickness, purely based on the mechanism. What you can see in this picture, and I'll just get this poll out of the way. What you can see in this picture is the area over the left scapula that is clearly blistered, and what you see under there is a pale, dry appearing dermis. So contrast this picture with some of the earlier photos where we had a pink, moist dermis that reflected the light. This is bone dry. So when you see really, really dry, dehydrated dermis, although it's kind of like a pink color, it's dry, pink, and pale. And I would say that that's going to be deep partial thickness. The other trap that we have to remember here is that have a look down at the top of his sort of buttock area and the flank, right down the bottom, just above the sheet. that is his normal skin color. If you go up a little bit higher, just under that blistered area on the left flank, that is not normal skin. If you put on a pair of gloves and you get your fingernail and you scrape the epidermis in that area, that whole area will actually be blistered. And what we're seeing here is actually this poor guy's back is completely burnt. It's all partial thickness, and it might be full thickness in areas, but the whole thing. So if we get out a London Browder chart, this is probably about 13%, 14% area of partial thickness burn. So all of that discolored areas down the paraspinal muscles and over both scapulae, down the flank, each flank and the lower back, all of that is a blister. It's just a blister that's stuck on to a dry dermis. So we do this test called a Nikolsky. It's called a Nikolsky sign. If anyone remembers that, it's where you put on a glove, you use your fingernail and you scrape the epidermis. If the epidermis scrapes away, then by definition, you've got a partial thickness burn. So most of this guy's back is at least partial thickness. So it's not an epidermal burn. That's why I've ruled that out. I've ruled out superficial partial thickness purely based on the mechanism and the fact that the dermis appears pale and dry. So I would say, and it's not really a red color, it's more of a pale sort of pink color. So I would say it's at least deep partial thickness. So yeah, thank you for answering those poll questions for me. I think that was good. I think that was worthwhile. The other thing that happens with burns, and we've already mentioned the fact that burns are not the same depth. You know, if you've got a burn, you often have a mixture of depths throughout the burn. The other thing that tends to happen is burn depth can change over time. And as the colors would suggest there, burns usually get deeper over time. If it's going to go one way or another, burns usually get deeper. And we refer to that as burn wound progression. And there's a few things that might affect burn wound progression or things that affect healing. So number one is the depth and location of the burn. So the deeper the burn is, the longer it will take to heal. So epidermal burns will heal within a few days. Superficial partial thickness burns tend to heal within 7 to 10 days. The mid-dermal burns tend to take around 2 weeks. And if you've got a deep partial thickness burn, it's going to take longer than 2 weeks as a general rule. The location of the burn is also important. So the further away from the heart the burn is, the longer it will take to heal. So we know from experience that burns on the lower limbs and in distant parts of the circulation, they will take longer to heal than the central parts of the body. As mentioned at the start, I work at the Royal Brisbane Adult Burns Unit. So different burn units around the country may have slightly different take on this, but generally speaking, we want burns to heal within 2 weeks. There's this sort of 2-week rule that most of us stick to. And if a burn is going to heal within 2 weeks, what that means for the patient is that they're very unlikely to go on to scar or have any sort of functional limitation. If a burn is going to take longer than 2 weeks to heal, we would usually start to recommend surgery or skin grafting to the patient. Now, some burn units around the country might stretch that out to 3 weeks. And in particular, some of the pediatric burn units might stretch this out a little bit more as well. Because, you know, kids, we often try and give them the benefit of the doubt. We give them a lot more chance to heal on their own. And, you know, thus avoiding the need for surgery and skin grafting. The second thing that affects healing is patient factors. So that's not so much of a problem in kids' burns, but in adults, you know, they come with their comorbidities like diabetes, peripheral vascular disease, COPD, heart failure, and smoking. And when I said before about burn wound progression, you know, burns getting deeper over time, these are the things that contribute to that. The other thing is sort of advanced age as well. And we know that older people have a, you know, reduced capacity to heal. So if you're diabetic, your burn could look okay on day one, like it might look pink and moist and superficial partial thickness. But, you know, with poor blood sugar control, with that microvascular impairment of their circulation, by day 3, it might be deep partial thickness or even full thickness. And that is the natural history of a burn in someone with diabetes, for example. The third thing that affects healing is edema. Edema is like the enemy of healing. And lower limbs are at a particular increased risk of this happening because of the dependency. So when you burn your feet or legs, we always advise rest and elevation. We always talk about some sort of compression bandaging to control edema, and early physiotherapy and mobilization. So, you know, the patient can walk around and is encouraged to do so, but when they're sitting still or standing still, they have to be lying down or sitting down with their legs elevated to prevent swelling. And what I think is going on here with edema is what we're doing is we're increasing the distance that oxygen has to travel from the capillary to the cell where it's needed. That's what edema does. So there's kind of like a relative hypoxia at the cellular level. And so the burn wound might look okay on day 1, but with edema and swelling, it will progress and get worse by day 3 or day 4. So these are the sort of things we use on lower limb burns. That they're these sort of Pro-4 multi-layer dressings on the left, or you can just use tubular bandages, Tubi-Grips. 1 or 2 layers would suffice over the top of the burn dressings. And then another thing that might affect healing is burn wound infection. We know, again, from experience that lower limb burns are at increased risk. And also patients who have contaminated burns or patients with comorbidities are also at an increased risk. So diabetics, people who smoke, and then people who have their burn and then, you know, jump in a stagnant creek, or they roll around in the grass and dirt and things like that, they have an increased risk of burn wound infection. And the burn might be tracking along okay, and you're doing your dressings and it's going all right, but then you get a little bit of cellulitis around the burn, and then suddenly the burn progresses. You know, it starts off again, partial thickness, and then you get a bit of infection and the burn gets deeper. You know, we see that all the time. So we have to be mindful for infection when the burn heals. This is an example of an infected burn. So so the thigh on the right there, this is a deep partial, maybe even full thickness burn. We can see it's pale white. Excuse me. And what we are looking for in terms of infection is not the burn, we're not looking at the burn itself. What we're doing is looking at the normal skin around the burn. And I hope you can appreciate on this photo here that there is some cellulitis in the skin, the normal skin around this burn. This would indicate to me early burn wound infection. So this patient will need to be commenced on antibiotics, and we can talk about that in a second in a bit more detail. Actually, we'll talk about it now. So when we've got a patient with cellulitis, one of the things that we always recommend is marking the boundaries of the cellulitis so that you and the patient can keep an eye on things. At our unit, and again, you're going to get different advice based on, you know, where you work and the burn service that you refer to. But we would always suggest having a daily dressing, a silver-based dressing, and getting the patient to wash and shower each time they change their dressing. And there's nothing wrong with getting in the shower at home and just using soap and water. But you can use aqueous chlorhexidine as well, because washing the surface of the wound will help to keep colony counts down on the wound surface. It will also, by doing a daily dressing, it will also enable you to keep an eye on the cellulitis to monitor for signs of improvement or deterioration. And then we have to decide about oral antibiotics or intravenous antibiotics. And I think certainly at our unit, we have a low threshold of admitting patients with infected burns and commencing them on intravenous antibiotics. It's always better to err on the side of caution and recommend, admission to hospital because, sometimes if we get infection, if we get on top of infection early, we can sort of cut it off at the pass or stop the burn wound from progressing to a point where it needs a skin graft. And certainly if you've got patients who are older, diabetic, immunosuppressed, I would always recommend referral to a burns unit for intravenous antibiotics. Most of the time they're gram-positive organisms. So if you are going to start oral antibiotics, we have to just, the skin commensal organisms you want to cover. But if the burn, it's like a week down the track or the patient's immunosuppressed or diabetic, we have to consider the possibility of some mixed sort of gram-negative cover as well, because although early burn wound infections are usually gram-positive organisms, later burn wound infections are usually gram-negatives, and the most common one we see all the time is Pseudomonas. Okay, so next little section is on choice of dressings. So just quickly, epidermal burns, we've already talked about. We just need to use moisturizer on them, so we won't go into any more detail about that. Superficial partial thickness burns, so those really pink burns up in the superficial layers of the dermis, they require paraffin-based gauze dressings. Anything deeper, we recommend silver-based dressings. This is also what the Australian and New Zealand Burn Association recommends on their information sheet about dressings for small and minor burns. So it's hard to get 17 burn units across Australia and New Zealand to agree on a dressing. But these are some general guidelines that sort of most burn units will follow. So epidermal burns, moisturizer; superficial dermal burns, we use things like paraffin gauze, and the ones we have in Queensland are things like Gelinet, Xeroform, Bactigras, those sorts of things. But as soon as you get a mid-dermal burn or a deep dermal burn or a full thickness burn, we all recommend silver products. So Acticoat, Mepilex AG, Flamazine, and there's a few other silver-based dressings as well. I'll just show you, this is what Xeroform looks like. It's pretty popular, like it's a pretty common dressing, certainly in Queensland. I'm not sure about other states and territories, but if you don't have access to the Xeroform, you can just use like Gelinet or Bactigras. I think a big problem in general practice is just getting the size of the dressings right, because some burns are quite sizable and you may only have access to relatively small dressings. So if it ever gets to the stage where you're just sort of running out of dressings, then that would be the point at which you probably need to refer them to the local burn unit or at least get some advice. But you can see a little wodge of paraffin there on the tongue depressor. Paraffin's a really good emollient, and we often add that to the paraffin-based gauze dressing as well to give it that extra, moisture retention. Burns, in general terms, they like to be kept moist while they're healing. So we put the paraffin on the gauze or the paraffin on the patient, and then we layer up 1 or 2 layers of gauze dressings, and then we have some outer absorbent dressings and bandages to hold everything in place. This is burn on the foot, which this one of our nurses in the burns clinic has put the paraffin directly on the Xeroform gauze, and we're just lying it straight onto the burn wound. And then over the top of that, we'll put on some absorbent dressings and some bandages. This is that sort of blue line just to hold everything on, that blue line stocking. And then over the top of that, we'll often put the tubular bandages such as Tubigrip, which is a little bit more firmer compression. And we'll instruct this patient to go home, rest, elevate the leg, and we'll monitor them in the clinic every couple of days for signs of infection, for signs of edema and swelling. And you might have seen at the start, that's a pink burn. It's probably superficial partial thickness, so we're expecting that to heal. A little bit on silver-based dressing. So as soon as you get sort of mid-dermal, as I said, mid-dermal or deep dermal or full thickness burns, we always would recommend some sort of silver-based dressing. Silver as an element is bactericidal, and there's an association with using these silver products and reducing the incidence of burn wound infection. So the common ones that we use in Queensland are Acticoat, Mepilex AG, and Flamazine. If you're using Acticoat, you have to remember it needs to be kept wet. So patients will need to wet the Acticoat to keep the silver active. They need to do that regularly. We find in Queensland, adult patients generally are non-compliant with this, so we don't tend to use a lot of Acticoat dressings for adult patients. In kids, it's really good because the parents are usually, keep the Acticoat wet and moist all the time, but in adults, not so much. One of our favorite dressings is Mepilex AG. It's a foam dressing impregnated with silver, but it's the opposite of Acticoat in that it needs to be kept dry. And you can leave Mepilex AG on the wound for several days, 3, 4, 5 days sometimes. And then if you are using Flamazine, and I know that's sort of gone out of favour in some states, I think New South Wales don't use it anymore, but in Queensland we still do. We happen to think it's a really good dressing, when you've got infected burns or if you want to do a dressing every day. But just remember, Flamazine, if you are using it, needs to be changed every day. You can't leave it on for several days. It'll get sort of achy and sweaty and stink. This is us using Flamazine on a infected burn. This is that same burn I showed a photo of before. You can see the cellulitis in the thigh. We're using Flamazine, so we can do a daily dressing. We're going to admit the patient, put her on antibiotics, and we're going to change the dressing every day. This patient is probably going to have surgery within the next day or two as well. We use this sort of gauze dressing just to hold the Flamazine on so it doesn't sort of run off everywhere. And then on top of this, we put on some outer absorbent layers. One of the reasons burn units and some people around the country don't like Flamazine is that you get this pseudo-eschar that forms on the surface of the wound when you're using Flamazine. And it can sort of confuse you, and you might think it's a deep burn when in actual fact it's really just a layer of kind of Flamazine and wound exudate that sort of settles on the surface of the wound. Some people believe that this slows down or impairs healing, but it's a trade-off. Some people love Flamazine, some people hate it. And then this is a deep burn, probably deep partial thickness or maybe even full thickness. And we would recommend in this instance using a silver-based dressing. So this is just a little bit of Solicite gel or a wound gel that will just help keep the wound moist. And on top of that, in this case, we're using Mepilex AG. So it's a impregnated sort of foam dressing with silver in it. And we're going to leave this intact for a few days or until the patient needs an operation. And this patient's probably going to get a skin graft if they want to go ahead with that because it's a deep burn in an awkward spot. All right, so how are we going for time? We've got about 25 minutes left, so I think we're going all right. The next little section is on burns in special areas, and I'll just sort of go through this fairly quickly so that we've got enough sort of time for question and answers at the end. For facial burns, we always have to remember in the burns unit to check for visual acuity, and we have to do a fluorescein stain of the cornea to detect any corneal uptake, which might indicate a corneal injury and necessitate a referral to an ophthalmologist or or something like that. There's also with head and neck burns, always a potential for inhalational injury. So, getting a very good history about what happened. Was it in an enclosed space? Was there a lot of smoke, inhalation, all that sort of stuff is important. We don't use flamazine on the face because of eye toxicity, corneal damage, and the risk of blindness. So what we normally do for facial burns is use a combination of topical chloramphenicol Chlorsig ointment and or soft white paraffin or Vaseline or something similar to keep the face moist at all times. And it's important in males, if they do have a burn to the hair-bearing skin, that we encourage them to shave every day. Because if you let the beard grow, you'll get a buildup of, exudate and scabs and things around the hairs, which can block the follicles and cause folliculitis. So the patients are instructed to shave every day. And I know that might seem painful, but it's not as bad as it seems. The key is use lots of shaving cream and get a fresh, disposable razor each time so that you're not using a blunt one. And so we do that to prevent folliculitis. For hand burns, it's important you dress the individual fingers, not like make a mitten kind of dressing, because by individually wrapping the fingers, you can still get the patient to do their physiotherapy, their hand exercises. We haven't really talked too much about blisters, and maybe there's some questions at the end about that. But if there's any blisters on the back of the hands, particularly over the small joints in the hand, we would always recommend sort of aspirating them or de-roofing them if you can, just for the purpose of being able to move a little bit more freely, because some of these blisters are quite tense and do restrict movement. And some of them are quite painful when they're tense. So by aspirating them or de-roofing them, that can improve the mobility in the hand. Physiotherapy is important, and elevation and, again, rest helps to reduce swelling. For burns in the perineum, these are messy, dressings are difficult. You got to think about how the patient's going to go to the shower and go to the toilet. Generally speaking, after each bowel motion, after each, after they pass urine, they should be encouraged to probably shower and change the dressings. I mean, they're going to probably fall off anyway. But at least change them daily and after each bowel motion, etc. And we tend to get like a big continence pad or something similar and just smother the whole area with flamazine. It's probably Flamazine for perineal genital burns is probably the best, because trying to get gauze dressings to stick in those areas is nearly impossible. So just lots of Flamazine in a sort of pad or a nappy or a continence pad, and then just changing it regularly is the key. And then lower limb burns. So these are, and I sort of talked a little bit about this, earlier in the talk. Lower limb burns heal slower. They're prone to swelling, and they're particularly susceptible to burn wound progression, as well as infection. So, we have a very low threshold in our unit to admit patients with burns on their lower limbs, particularly if they're older, if they've got comorbidities, such as all those things. And we always consider, or we always practice edema control right from the start. So rest, elevation, and compression bandaging. And then contaminated burns, we've kind of also talked about as well. Patients often jumping into a creek, dam, ocean, rolling on the ground, etc. These wounds we know are more prone to infection. So we really have to get on top and clean these wounds well. We need to use chlorhexidine to sort of disinfect the wound and remove as much foreign material, debris as we can. Sometimes you need sedation for this. Sometimes it's a referral to hospital to have this done. And with contaminated burns, these are not the sort of burns that you want to wrap up and leave for 3, 4, 5 days with a nice silver dressing. on and leaving it intact. These burns, because they're more prone to infection, these ones probably should be changed every day so the patient can shower, continue to wash off all the debris and dirt, etc. And then we can, monitor closely for signs of infection. These are all my suggestions, by the way. I mean, when you speak to your burns unit, you're going to get slightly different advice, I guarantee it. But they're general principles more than anything else. And I would encourage you, as you probably have been doing all along, to discuss difficult cases or cases that you're concerned with the burns unit. So last few slides, 2 weeks is this golden rule. So if you have a burn and it's somewhere around the mid-dermal area, burns that are more superficial than this will usually take less than 2 weeks to heal. And, patients are often encouraged to stay in the community, get dressings through their GP or local hospital, and, they don't necessarily need to come to the burns unit. But as soon as you get a deep mid-dermal burn or a deep dermal burn or a full thickness burn, we know that they're probably going to take more than 2 weeks to heal. And therefore, these are the patients that you're probably going to refer to a burns unit. And if you've got a patient with, suboptimal conditions, so poor patient compliance, someone who's not going to keep their dressings on who delays seeking medical advice. If you've got elderly patients with comorbidities, patients who smoke, if you've got a burn wound infection or there's edema and swelling in lower limb burns, then that changes the dynamics of how things heal. And suddenly, superficial dermal burns, which would normally heal within 2 weeks, suddenly, in these sort of situations, they're going to take longer than 2 weeks to heal. And we often see burn wound progression. So if you've got any sort of complicated patients, again, with all those things down the bottom there, these are probably ones that you need to speak to us about. Okay, so I reckon we've left kind of 15 minutes or so for questions, and I can see a few on the Q&A slide there. So before we get to that, just in summary, when we're judging burn depth, I just recommend you consider taking a good history and considering the mechanism of the burn. And then you need to look at the color of the dermis. So you need to look under the blister. And there's only those 3 colors that you need to remember: pink, red, and white. Pink superficial, white is deep, and red is somewhere in between. 2 weeks, some units might stretch this out to 3 weeks. But aim to have all burns heal within 2 weeks. If you're still seeing a burn and it's 3, 4, 5 weeks down the track, things aren't going right, and that patient will probably need a skin graft. So there's that 2-week rule to remember. Please be aware of factors that delay or prevent healing. So we've talked about that: elderly patients with comorbidities, etc. And select appropriate dressings based not only on ANSPAR guidelines, but more importantly, your local burn service preferences. So thank you very much. I might open the Q&A box and start answering some questions, but someone had their hand up too. So, first question. Hi, Shirley. Are you happy if I just answer these?
Yeah, absolutely.
So Cathal Ahern. So there was a question: is the presence or absence of body hair in the burn immediately after a burn any indication of depth? Not. Sometimes it is. So if the burn is on a hair-bearing part of the skin, and you sort of grab one of the hairs and try and pull it out of its follicle, if they say if it comes out easily, then that is an indication of a deeper burn. Whereas if there's some resistance, it means the follicle's probably still alive, the burn's not as deep. So there is that. But the absence of hair could be because the hair itself has been burnt off, and we typically see that in flame burns, but that doesn't necessarily mean it's a deep burn. If the hair's burnt off, you could still have a pink superficial partial thickness burn. I don't know if you remember that the young guy at the back of the calf, it was a pink moist burn. I think his hair had been burnt off, but it was still a pink burn. Hopefully that answers that question. Question from Kai Tan, full thickness burn is much less painful. Absolutely. Full thickness burns by definition have probably most of the nerve endings damaged, if not completely just cooked, so that they will often be less painful and insensate to examination.
Karen's question is in reference to the young bloke whose shirt caught on fire, I think, whilst welding.
Yeah. So he needed a skin graft. So that his whole back would have needed a skin graft. So that 13-14%. That was a very deep burn, but he did fine because he's young. Young people do well in general. Dr. Afro, so do you de-roof all blisters or just over the joint? And I didn't put in my slide on blisters because it is a bit controversial, and you will get different advice from different units. And I tried to just sort of sit on the fence on this one. Generally speaking, at our unit, we are very conservative with blisters. We usually just leave them intact if they're not causing any problems. The times they cause problems are in the hands over small joints and they're affecting your movement. We would de-roof them or aspirate them in that situation. But most of the other time, I mean, you probably saw us put the dressing on that young girl's foot, the Xeroform yellow dressing, and there was a blister intact. We didn't even sort of touch or de-roof that blister. There are some people out there that think the blister fluid's good and the blister is like a good biological dressing. And we're sort of more in line with that. What you don't want to do is, first of all, leave big, large blisters, tense blisters on the back of the hands. But you don't want to, get down the track and it's like a week down the track and the blister's still there. What will happen to that blister fluid is it will start to get colonized and could potentially turn into like an abscess or trap infection under the blister. So if you've got a week and a half old burn and there's blistered skin still there, we would normally de-roof the blister in that situation. So it's not necessarily just over the joint. It might just be, depending on a few different things. Thank you, Karen, for the feedback. And I think I've answered the next question, Dr. Kairon, regarding blister management. Again, I'll just say that it's controversial and you will get different answers from different burn units. And I think, the difference between adults and kids is probably different as well. Certainly within Queensland, I know at the Queensland Children's Hospital, they're much more liberal with removing all the blisters and de-roofing everything and putting a dressing directly on the burn, whereas in adults, we just leave things alone. Next question from Daniel, what's the role of capillary refill? Yeah, I think there is a role. It's just that it's just not one that I'm commonly exposed to because I get most of my referrals via email. Most burn units around the country now will have an online email system where you can send photos and get advice. I've got no way of knowing if there's capillary refill. All I can go off is a history, a mechanism, and a photo. So I'm using capillary refill less and less in my clinical, skill set, and I'm just relying on the color of the burn now. But absolutely, if there's capillary refill, that probably mean it's a superficial partial thickness burn. If there's no capillary refill, then it's probably deeper. And likewise, tenderness or pain on palpation and touch becomes less the deeper the burn is. So yeah, that still holds true, but it's just not something that I use in my everyday practice. The next one, Dr. Bateni, Do you reckon irrigation with saline solution, diluted TCA or vinegar? In terms of first aid, look, it's just cool running water, 20 minutes from a tap. But in terms of cleaning a burn wound, you know, don't forget just a normal shower. Warm soapy water with body wash or soap is absolutely fine. You don't need sterile saline. You know, when you're doing a dressing, it's not a sterile procedure. It's just a, you know, it's a tidy sort of clean procedure. So you don't really have to use saline solution. You can just use water from the tap. It's absolutely fine. In the burns clinic at the adult hospital, it's tap water. It's nothing special. But we don't use vinegar or any other solutions like that. It's just sort of warm soapy water normally. If we're worried about a contaminated wound or an infected wound, we would use aqueous chlorhexidine to sort of help with some antisepsis. Dr. Hampton, a 15-year-old who fell asleep in the sun, entire back was bright pink with multiple blisters. What would be the best treatment, including dressing, be for this? So this sounds like to me like a superficial partial thickness burn based on the mechanism, a sunburn, and the fact that it's pink. So Ansbach recommendations is paraffin-based dressings, and that's probably what we would do for this young girl. So Xeroform, Bactigras, or Gelinet sort of dressings. Plus a nice thick layer of paraffin itself, you know, soft white paraffin. And that would be changed every 2 days, depending on how much paraffin you use. And that would be dressed until it healed, basically. Dr. Tan, how do we dress the burn before we send them off to ED? That's a good question. If it's a burn you're concerned about that needs an assessment from the burns unit, the best thing is Glad Wrap or Cling Wrap, because whatever you put on, we're just going to take off and throw in the bin. And so don't use Acticode or Mepilex AG or some expensive dressing, because the first thing we'll do is remove it when the patient gets to us. Cling Wrap is good for several reasons. One, it's cheap. Two, it's good pain relief. You know, when the air gets to a burn, it stings. By placing Cling Wrap over it, you'll actually help the patient's pain relief. And when you've got a major burn, like, you know, the EMSB course teaches us to cover major burns with Cling Wrap, because it actually is a really good way of preserving body heat and preventing hypothermia. But that's not the case for minor burns. It's not an issue. Shay is the next question. Do you find that you get hospital admissions based on medical practices not having the right dressings? Yes, absolutely. I think it's a big problem in general practice not having access or stocking adequate size dressings, because most of the burns we see, most of the burns that come to hospital are quite significant. I mean, apart from the little ones that are, you know, a 50-cent piece or something, a lot of them soak up quite a lot of dressings, and you know, it's easy for us because we have a high turnover. We use dressings and we're constantly replenishing them. And we also have gauze dressings on the roll, like a big roller of them. Whereas in the pharmacy or the chemist, when you buy them, it's a little postage stamp, which is completely useless if you've burnt the whole back of your hand. You know, you'd need like 25 little postage stamps to make up a dressing, and then they all slip and fall, and you know, that's not adequate. So yes, we do get a lot of admissions and referral to the burns unit for dressings, but that's absolutely fine. That's what we're here for. Flaminol, there's a question from Amanda about Flaminol. Yeah, we actually in our unit used it for a little while. We actually think it's quite reasonable. Flaminol's another kind of dressing that keeps, you know, it's sort of got some antimicrobial properties. It keeps the wound moist. Absolutely, it's one of the things that you have in your arsenal, and there's nothing wrong. I think the thing with dressings is, you know, we always tell people, excuse me, you can use whatever dressing you want, as long as you use it correctly. You know, so if you're going to use Flaminol, you know, get some training in it, speak to the rep to see how it's used. If you're going to use Acticode, it needs to be kept wet. If you're going to use Mepilex AG, you keep it dry, etc. So any dressing is fine, especially on those really superficial pink burns. You can pretty much put anything on them and they're going to heal if you've got the right patient, a young patient, no comorbidities. you know, and you're not worried about swelling and infection, that you can put anything on it and it's going to heal. Yeah, that's fine. Beth, how do you know what the skin color is if the blister is covering it completely and don't de-roof it? That's a good question. You sometimes don't know initially. So you could leave the blister intact, dress it, and get the patient back in a couple of days' time, by which time the blister might have started sort of de-roofing and coming away itself. Or you can get a pair of scissors and forceps, give it a little snip, have a little peek underneath, and you can look at the color of the dermis straight away. The thing about blisters is, and I think the reason we're a little bit more conservative with our patients in Queensland, is as soon as you start de-roofing blisters or aspirating them, the patient's pain is an issue. So if you know that hand burn with that massive blister you saw at the start, when you take that blister off and it's within the first few days of the burn, you're going to struggle doing that in your rooms, in your clinic. You know, if they were in the burns clinic, they would probably be given some pre-medication with something. They would probably use Entonox as an adjunct to sort of pain relief. And if they were on the ward getting, you know, in the burns ward getting dressing changes, they would have, you know, intravenous, parenteral, analgesia, all that sort of stuff. So removing the blisters, you know, a big downside of that is actually pain and, you know, the comfort for the patients. Dr. Hearn, oral antibiotic choice. Yep. So flucloxacillin is our first line antibiotic, oral antibiotic or intravenous antibiotic in Queensland for adults. But when we have a diabetic patient or an immunosuppressed patient, or if the burn is, say, more than 5, 6, 7 days old and we've got infection, we know those sort of patients have more gram-negative infections, so we would broaden that. If I prescribed, for example, the other day I had a diabetic with a week-old burn with some infection, I prescribed Augmentin Duo for that patient, and if they were being admitted, they would usually be on Piptaz, intravenous Piptaz. Next question is, can you aspirate the blister? Absolutely. That's one of the options. You know, your 3 options really for blisters are you leave them alone and don't touch them. 2 is you aspirate them and just let the fluid out and keep the skin on. Or the 3rd option is you de-roof the skin completely. And again, you're probably just going to get advice from the burns unit if you want, because everyone's going to do it slightly differently. But generally, state by state, territory by territory, we kind of all do things in a similar way. You know, within Queensland, it's you know, consistent advice for adults. You know, it's easy for us because we're the only burns unit in Queensland for adults, so we can give consistent messaging across Queensland. But I know in for example, New South Wales, there are 2 burns units. Hopefully their sort of messages are aligned, but, you know, depends on the day, I suppose, and who you talk to. Shay, do you see a high presentation of ED by emergency service personnel? Yeah, sometimes. We had the unfortunate accident back early this year where there was a building structure fire on the south side of Brisbane, and 2 firefighters ran in, and both of their breathing apparatuses failed. They collapsed within the building and they had to be rescued. And this is sort of all public knowledge it was on the news and everything, so I can sort of talk a little bit about it. But one of the firefighters was deceased on the scene and couldn't be revived, and the other was treated in our burns unit and has managed to survive. And their burns were deep because of the, you know, that temperature and time sort of phenomenon, you know, hot temperatures for a long time. So we're talking, you know, deep dermal, full thickness burns. It's very rare for firefighters, actually, I would say, to be burned because they do have good safety equipment and training. Police, almost never. I can't remember when I treated a police officer for a burn. maybe 1 or 2 over the last sort of 8-10 years. What's more common is the amateur firefighters or the rural fire brigade, you know, getting caught in a grass fire or a bushfire or something like that in crosswinds. And we've had a few of them over the years. And if you're engulfed in a bushfire, chances are your burns are very deep and it's a major burn. Dr. Hampton, emollient, what's the best emollient? Something that's cheap, something that's plain, readily available. So for that reason, we just use sorbolene most of the time. If they come to our clinic, they'll just be given a tube of sorbolene or some sort of, you know, some sort of cheap moisturizer, nothing fancy. Another question, a patient applied cling wrap to his chemical burn and the cling wrap melted onto his burn. When is it safe and when is it not? I haven't heard of that happening before. When you've got a chemical burn, just remember the first aid is a little bit different to a thermal burn. A thermal burn's 20 minutes of cool running water. If you've got a chemical burn, it's copious irrigation, and you might need to, you know, stick the patient under the shower for half an hour or 60 minutes and really dilute the chemical off. If you put the cling wrap on too early, maybe some chemical residue, you know, melted the cling wrap. So that might be an indication that, you know, there's been inadequate first aid. Generally speaking, if you've got good first aid, even if it's a chemical burn and you've got off the residue or residual chemical, cling wrap should be safe. And for all thermal burns, it's probably fine. And then another question, if burns involve hot fluid over clothing and the clothes stuck, should be kept intact, should the clothes be kept intact and not removed? So if the clothes are kind of stuck onto the skin, yeah, so we'd always recommend removing items of clothing and jewelry, because they can act as a heat sink and cause further burning. So if there's any clothes, and this is particularly an issue with the synthetic fabrics, try and remove it if possible, because it might be hot and causing further damage. So if you remove a bit of melted on nylon from the skin and the blister comes off with it, that's not the end of the world, because the blister is going to come off eventually. What's more important is you get off all of the clothing, and that's what will happen when they get to the burns. You know, we'll scrub them and we'll try and get all of the material off the patient. So generally speaking, you try and remove it. And another question about does ANZBA or myself have an opinion on decontamination and chelating agents? Yep. So the dofodorine is usually, yeah, that's standard in a lot of industries now. So they have first aid stations, and most, you know, industrial areas and mines and things like that will have dofodorine solution. It hasn't yet made its way into the ANZBA or EMSB teaching manuals, but it's very commonly used in industry. So I think it's great. It chelates a lot of chemical burns, but we just haven't, you know, updated the manual to reflect that.
Thank you, Carl. I think that's all the questions.
Oh, awesome. Thanks.
So thank you so much for a very clear and easy to remember and I guess action presentation for us about burns. So thank you so much.
No worries. Thank you. Thanks for having me again.
Thanks, everyone. Helen, I don't know if you want to